Most students try to memorize obstructive jaundice as separate symptoms, separate investigations, and separate surgeries. But actually, obstructive jaundice is one very logical disease process. If you understand the pathophysiology, then you can predict the symptoms, examination findings, blood results, complications, and even management. So today, let's understand obstructive jaundice clinically like a surgeon, not by memorization. The basic concept that you have to understand is that normally the bile is produced in the liver. Then it travels through the biliary tree and finally enters the duodenum. Bile is very important for bilirubin excretion, fat digestion, and absorption of fat-soluble vitamins. In obstructive jaundice, something blocks this pathway. So, the bile can't enter the intestine. Why jaundice occurs? Now let's think logically. Bilirubin is conjugated in the liver and normally excreted into bile. But when bile flow is obstructed, conjugated bilirubin cannot drain into the intestine. So it refluxes back into the bloodstream. That is why obstructive jaundice causes predominantly conjugated hyperbilirubinemia. So then, why the dark urine? Students often memorize dark urine, but why does this happen? Because conjugated bilirubin is water soluble, so the kidneys filter it into urine. That produces dark urine. Why the pale stools? Normally bilirubin enters the intestine and it becomes stalk bile, which gives the stool its brown color. But in obstruction, bilirubin never reaches the intestine, so stools become pale or clay colored. Why pruritus? Why do these patients itch? Because bile salts accumulate in the bloodstream and deposit in the skin. This irritates the nerve endings and causes severe pruritus. That is why you may see scratch marks during examination. Why the steatorrhea and bleeding? Now another important concept. Bile is needed for fat emulsification and absorption. So when the bile can't enter the intestine, the fat absorption decreases. As a result, patients develop bulky, greasy stools, steatorrhea, and deficiencies of fat-soluble vitamins, vitamin A, D, E, K. Vitamin K deficiency is surgically very important because vitamin K is needed to produce clotting factors. So patients develop prolonged VTINR, bruising, and bleeding tendency. Now we'll go for the causes. Now students panic trying to memorize the causes. Don't memorize randomly. Think anatomically. Anatomically like extraluminal causes, intraluminal causes, and intramural causes. Extraluminal causes. Things outside the duct can compress it. For example, pancreatic head carcinoma, enlarged lymph nodes, periampullary carcinoma. Remember, the common bile duct passes through the pancreatic head. So pancreatic head tumors commonly causes obstructive jaundice. Intramural causes. Diseases within the duct wall, which include cholangiocarcinoma, biliary strictures, sclerosing cholangitis. Intraluminal causes. Things inside the lumen, which include the common bile duct stones, parasites, sludge, and blood clots. Then, another important concept, one of the most important clinical concepts I'm going to talk now is painful versus painless jaundice. Painful jaundice. Stones usually cause sudden obstruction. This rapidly increases the ductal pressure and inflammation. So patients develop severe pain. Painless progressive jaundice. Compared to that one, malignancy causes slow gradual obstruction. The biliary tree dilates slowly over the time. So jaundice becomes progressive and often painless. Therefore, a patient above 40 years with painless progressive jaundice must be considered malignant until proven otherwise. A patient above 40 years with painless progressive jaundice must be considered malignant until proven otherwise. Okay, now we'll go for the history taking. When taking the history, think like a surgeon. Ask about the duration, progression, pain, fever, weight loss, stool color, urine color, and pruritus. Then another thing, fever and the cholangitis. If jaundice is associated with fever and chills, think of cholangitis. Weight loss. Weight loss and anorexia strongly suggest malignancy, especially pancreatic carcinoma. Courcier's law. Now let's understand Courcier's law logically. Stones. Gallstones usually cause repeated inflammation over many years. So the gallbladder becomes fibrosed and contracted. But in malignant obstruction, which develops gradually without repeated inflammation, so the bile accumulates slowly, causing the gallbladder distension. That is why a palpable non-tender gallbladder with jaundice suggests malignancy until proven otherwise. Then the Charcot's triad and the Reynolds pentad. This is a very high-yield exam area. Charcot's triad. When bile becomes stagnant, bacteria can ascend from the intestine into the biliary tree. This causes ascending cholangitis. The patient develops fever, right upper quadrant pain, and jaundice. So this is Charcot's triad. In Reynolds pentad, if the infection becomes severe, the toxins enter the bloodstream causing septic shock. Then patients develop hypertension, altered mental status, and this becomes Reynolds pentad. This is a surgical emergency. Then the examination. On examination, look for deep jaundice, scratch marks, palpable gallbladder, hepatomegaly, fever, and signs of chronic liver disease. Then the investigations. Now investigations become easy if you understand this pathology. Okay, so we'll go for this LFT pattern. Obstruction damages the biliary canalicular system. So the cholestatic enzymes rise markedly, ALP and the GGT. AST and ALT may rise mildly, but not as much. So the classic obstructive pattern is markedly elevated ALP and GGT with conjugated hyperbilirubinemia. Then we go for the imaging and the biliary evaluation. First line imaging is ultrasound scan. Why? Because obstruction causes proximal duct dilation which the ultrasound detects very well. Ultrasound scan can identify the dilated ducts, gallstones, liver lesions, and gallbladder enlargement. CT scan. CT scan is excellent for pancreatic masses, metastasis, and staging. MRCP. MRCP beautifully visualizes the biliary tree non-invasively. It is non-invasive. ERCP. ERCP is both diagnostic and therapeutic. You can identify the obstruction, remove the stones, place the stents, and decompress the biliary system. Okay. Now we'll go for the management overview. Management always has two goals: relieve the obstruction and treat the underlying cause. Why to relieve the obstruction? Why we relieve the obstruction? Because prolonged obstruction causes sepsis, liver dysfunction, coagulopathy, malnutrition, and renal injury. For the benign causes, for common bile duct stones, we can go with ERCP plus stone extraction. Then definitive surgery if needed. For the malignant causes, if resectable, perform curative surgery. Whipple's procedure. Whipple's procedure is mainly done for pancreatic carcinoma. Remember the anatomy. The pancreatic head is closely related to distal common bile duct, ampulla, and the duodenum. So these structures are removed together. Unresectable cases. If the disease is advanced, palliative stenting or bypass is performed. Even if cure is impossible, relieving obstruction improves the jaundice, appetite, pruritus, liver function, and quality of life. Next, we'll go for the complications. Untreated obstructive jaundice can lead to ascending cholangitis, biliary cirrhosis, hepatic dysfunction, vitamin deficiencies, coagulopathy, sepsis, and renal failure. Now let's discuss the management of cholangitis properly. Remember, ascending cholangitis is not just infection, it is infection plus obstruction. So, antibiotics alone are not enough. Why does cholangitis become dangerous? Normally, bile flows downward and helps prevent bacterial ascent. But obstruction causes bile stasis. This allows bacteria from the intestine to ascend into the biliary tree. Pressure inside the biliary system increases and bacteria plus toxins can enter the bloodstream. That is why patients can rapidly develop sepsis, hypertension, and multi-organ failure. The initial management starts with ABC resuscitation, airway breathing and circulation. IV fluids. These patients are often septic and dehydrated, so aggressive IV fluid resuscitation is essential. Antibiotics. Start broad-spectrum IV antibiotics immediately because common organisms are enteric gram-negative bacteria like E. coli, Klebsiella, Enterococcus. Correct the coagulopathy. Remember, obstructive jaundice causes vitamin K deficiency, so the PTINR may be prolonged. Correct the coagulopathy if procedures are planned. Most important step. Definitive treatment is relieving the obstruction. Definitive treatment is relieving the obstruction. This is the most important step because as long as the obstruction remains, infection cannot fully resolve. So we go for biliary decompression. This is usually done by ERCP, sphincterectomy, stone extraction, or stenting. If ERCP is not possible, PTBD, percutaneous transhepatic biliary drainage. This may be needed. Then the preoperative optimization. Now before major surgery, these patients must be optimized carefully. Why? Because obstructive jaundice affects multiple organ systems. Infection control. First treat any active infection, especially cholangitis. Correct the coagulopathy. Correct vitamin K deficiency using vitamin K, FFP if needed. Nutrition. Many malignant patients are malnourished, especially pancreatic cancer patients. Poor nutrition increases the wound complications, infections, delayed recovery. Correct the anemia and the electrolyte imbalance before the surgery. Biliary drainage before surgery. Sometimes severe jaundice requires preoperative biliary drainage. Why? Because prolonged severe obstruction increases the hepatic dysfunction, renal injury, and postoperative complications. Then the Whipple's procedure. This is a famous surgical topic. Now let's discuss the Whipple's procedure. Indications. Whipple surgery is mainly performed for pancreatic head carcinoma, periampullary carcinoma, distal cholangiocarcinoma. Why such a large surgery? Because anatomically the pancreatic head is closely related to distal common bile duct, duodenum and ampulla. So tumors in this region spread locally very early. What is removed? In classical Whipple procedure, the surgeon removes the pancreatic head, duodenum, distal CBD, gallbladder and part of the stomach. Reconstruction. Then reconstruction is performed using pancreaticojejunostomy, hepaticojejunostomy and gastrojejunostomy. Complications. Major complications include pancreatic fistula, delayed gastric emptying, bile leak, hemorrhage and infection. Students often fear Whipple surgery, but remember the logic. All these structures are closely attached anatomically, so they are removed together as one surgical block. Then the palliative biliary drainage. Now, not every patient is suitable for the curative surgery. Why? Many patients present late with metastasis, vascular invasion, and unresectable tumors. Goal of palliation. Now the goal is not curing, not the cure. The goal is symptom relief and quality of life. Why relieve the obstruction? Persistent obstruction causes severe itching, anorexia, liver dysfunction, recurrent cholangitis, and weakness. We go for ERCP stenting. So ERCP stenting is commonly performed. The stent keeps the biliary pathway open, allowing the bile drainage. This improves the jaundice, pruritus, appetite, and liver function. PTBD, percutaneous transhepatic biliary drainage. If ERCP cannot be performed, PTBD may be used. Okay. Now let's finish with the most important take-home messages. Key point 1. Painless progressive jaundice in an older patient is malignancy until proven otherwise. Key point 2. Painful jaundice usually suggests stones or cholangitis. Key point 3. Charcot triad. Fever, right upper quadrant pain, jaundice. Key point 4. Renault pentad. Renault pentad means severe ascending cholangitis with sepsis. Key point 5. ALP and GGT rise markedly in obstructive jaundice. Key point 6. Ultrasound scan is the first line imaging. Key point 7. ERCP is both diagnostic and therapeutic. Key point 8. Always relieve obstruction before major surgery if possible. Okay. So, obstructive jaundice is not just a topic to memorize. It is a logical sequence. Obstruction causes bile stasis. Bile stasis causes jaundice, pale stools, dark urine, itching, infection, then the malabsorption and eventually organ dysfunction. Once you understand the mechanism, the entire topic becomes easy. If this helped you understand surgery logically, instead of memorizing blindly, follow for more high-yield ERPM and final MBBS surgical teaching. Thank you.